Okay, so this video is the continuation of the discussion of how to design a healthcare system that work. And chapter 18 is going to focus on the American model. The American model is very unique. Unlike the other developed countries, it doesn't have a universal guaranteed insurance for all citizens. While it takes a combination of employer-based insurance, Medicare and Medicaid. So this mixed of private and public insurance is a hallmark of the American model. Some characteristics. First, there is a private health insurance market. The non-elderly and non-poor seek insurance on the private market, and this is mostly centered around employer-based health insurance pools. Second part is that it has a partial universal health insurance for the old and the poor. The third characteristic is that provision is private. Most hospitals and doctors are private. They have a lot of freedom to choose what they want to practice and how they want to practice. While there is some antitrust regulation, there are few legal restrictions on where they can open. And there are also no direct price controls enforced by the government. So this is a model that reflects a political preference for liberty and free choice. On the patient side, they have free choice of doctor, hospital, and insurance plan. On the doctor side, they also have free choice of prices to charge, where to practice, and whom to treat. So we're going to start talking about this whole model by first focus on employer-sponsored health insurance. For most of the people in America that is not old, they usually receive their coverage through the employer. This insurance is not technically there, it's not free because it's a part of the package of their compensation. So the cost of premiums are taken out from the workers' wages. The fact that the cost of insurance effectively come out of the wage is called wage pass-through. So for the same type of job and skill level, jobs without insurance plan may offer a higher wage than jobs without them. This model is nice for combating adverse selection because it provides a reason for employees to pull together. So for every company, there will be healthy employees, there will be less healthy employees, and they are together instead of the healthy employees choose to keep dropping out. And that is a problem that we see in adverse selection. However, not all members of an employer-sponsored plan are together in a single pool. So sometimes if a firm has a set of employees that are young, a set of them are old, the younger one have lower expected cost, and the firm would sometimes likely to use a wage pass-through to charge the older ones more for their health insurance. So in this case, the younger ones don't need to subsidize their older colleagues for their health insurance. And in this case, they will be less tempted to leave for the other firms. Differential wage pass-through can occur whenever employers can observe elevated health risks among their employees. Technically, if this is done, very obviously, it's illegal in the US. But wage discrimination is difficult to detect. And there is evidence that people who have higher expected medical expenditures do earn less. So here is some examples. In 1976, there is a law that passed that mandates maternity leave, maternity care coverage for employer-sponsored insurance plans. And after this law has passed, there is evidence that showed women of childbearing age saw their salary fall relative to both men in the same age and older women in the years after the passage. Another example is that obesity discrimination. So in jobs with employer-sponsored health insurance, the obese colleagues earn less than their thin coworkers, while in jobs without insurance, the differences is not significant. So here's a graph. So in the right-hand side, you can see that the thin and obese workers, their wage is relatively similar if they are working in jobs that don't provide health insurance. While in the left-hand side, you can see that the thin workers' wage line is above the obese workers' wage line. And this is because the companies provide them health insurance. Now, we find this evidence that there's discrimination against people's health status in terms of their wage, but it's actually difficult to detect unless we have enough data. That means if we go to one person's case, it's actually difficult to argue that he or she has a lower wage because of his ability, his productivity, or because of his health status. Okay, so why don't these employer polls have adverse selection problems? How do they combat that? Theoretically, if healthier workers can find desirable new jobs elsewhere where they do not need to subsidize their unhealthy colleagues, they have every incentive to leave their current jobs. So why do they stay? We call this firm-specific human capital. We defined it as knowledge and experience gained from working at a particular firm that is highly relevant, but irrelevant at another companies. So these healthy colleagues want to leave because they don't want to subsidize for their not so healthy colleagues. But at the same time, if they leave, they probably will see their salary dropped because of firm-specific human capital. So this creates an incentive for them to stay in this pool. We call this job lock. So the confluence of employer-sponsored health insurance, wage pass-through, and sticky wages is known as this term called job lock. Through job lock, it distorts labor markets and can reduce social welfare by creating inefficiency. Now, if you consider an employee who is bound to a wheelchair by multiple sclerosis, despite that he has higher healthcare costs, his wage have not been cut because of wage pass-through since his diagnosis. So now he is subsidized by his healthier colleagues. So suppose this employee would be a better fit for a new job opportunity elsewhere, but his potential new employer, knowing that he has a wheelchair, lowered his offered wage to compensate for an anticipated rise in healthcare premiums. So this lower offer deters this worker from switching jobs. And so he stays unhappily and inefficiently at his current one. We believe that this worker would be more productive at a new job. This is our assumption. So it would be socially efficient for him to switch, but job lock discouraged him from doing so. This is why we argue that job lock is an inefficiency. But while job lock reduces voluntary employee turnover rate by 25%, the total cost of job lock, according to studies, is modest, which is less than 0.1% of the GDP. The social loss from job lock may be this modest because of policies aimed at mitigating the harm caused by it. So we will not talk about it, but the idea is that even though employer-sponsored insurance creates job lock, creates this inefficiency, but nice thing is that it combats adverse selection. And so balancing adverse selection and job lock, it's nicer to have job lock rather than severe adverse selection. Okay. The next part, we're going to talk about the managed care alternatives. So in the middle of the 20th century and all the way into 1980s, the US private market was dominated by this called indemnity insurance. This type of insurance is also known as fee for service, FFS, because customers receive healthcare, let's say different tests, different procedures, and then the insurance company will pay the doctors or the hospitals a fee for every service that they practice on this patient. Coverage for specific treatment was rarely denied, even costly ones that provided minimal benefits. So this fee-for-service model did little to contain moral hazard. And we can imagine that this provides ample incentive for physician-induced demand. So here's a story of the Kaiser Permanente. So the Kaiser managed care plan began as a communal insurance pool for workers in California shipyards during the World War II. Henry Kaiser realized that it would be cheaper to provide medical care for their employees directly rather than paying it at outside hospitals. So in the decades after him was funded, more insurers began offering managed care plans. Okay, so what exactly is managed care? Managed care is a philosophy of health insurance that employs tactics intended to reduce moral hazard, physician-induced demand, and premiums. And so here are some of its tactics. The first one is gatekeeping. Patients can only see specialists or surgeons after their generalist primary care doctors approve them. The second part is coverage network and vertical integration. That patients can only receive care from a specific list of providers because the providers and the insurance have integrated each other together. There's monitoring. Hospitals and doctors are monitored for costs and health outcomes so that they cannot spend too much money with only limited amount of improvement in health. There's also salaries and fixed payments. The insurer pays a fixed amount of care instead of fee for service. There's denial of coverage, that some care may not be covered if it's not cost effective. In 1973, federal law established the term HMO, Health Maintenance Organization, to devote a vertically integrated managed care organization like the Kaiser. This is another type of managed care option is called a preferred provider organization, PPO. And a PPO is a less restrictive version of HMO that does not integrate insurer and provider. US customers and employers have gradually get used to HMO and PPO from the expensive fee-for-service insurers. So here is a graph that depicts the percentage of insurance care. In 1988, 73% of the insurance are conventional. Only 16% are HMO, 11% are PPO. Versus fast forward to 2008, only 2% remain conventional, which does not control much moral hazard. Majority becomes PPO, 20% becomes HMO. Okay. So does managed care work? A study by Gottfried and Sloan, 2002, find that there is no systematic differences in health outcomes between managed care and fee-for-service. But managed care do keep the costs lower. So this is nice that they control moral hazard without sacrificing too much health. One important caveat is that managed care plans tend to attract healthier consumers due to adverse selection. If this is the case, managed care might be reducing costs simply because their customers are healthier. An interesting side note is that academic researchers who study managed care professionally are less likely to personally enroll in managed care plans themselves. Okay, so now we're going to talk about Medicare and Medicaid. The Medicare program is a government insurance program that provides insurance coverage to 48 million elderly and disabled people as of 2012. It has 4 parts. Part A pays for their hospital care. Part B for outpatient and physician care. Part C is an option that they can receive their health insurance from a private plan rather than through A and B. And Part D pays for their prescription drugs. In terms of premium, in 2022, the premium is still relatively controlled. So for example, Part A charges around $274 to $500 monthly premium. Part B is $170 monthly premium, and it varies by income. Part C and D is more flexible. So the premium there can be really low or can be as high as possible. All the American citizens over 65, once they get 65, they can get Medicare. Or disabled Americans who have been out of work for 2 years, they are also eligible to enroll. It is very expensive because this type of population, this group of population are just generally less healthy and needs much more healthcare than the other. It also reimburses for any procedure that is shown to be medically effective, irrespective of cost, because Medicare was banned from doing cost-benefit analysis. It sets premiums far below its actually fair level. Because it serves as a welfare program. It serves as a nice program for people who cannot afford healthcare at that age. And so this means that a large amount of the money comes from taxpayers. In order to do cost control in Medicare, it has several mechanisms designated to mitigate it, even though cost-benefit analysis is not allowed. So in both Medicare Part A and B, patients face cost sharing in some forms, for example, deductibles or co-payments. However, most Medicare enrollees also purchased some private supplemental insurance called Medigap plans, which pay for their deductibles and co-payments, and thereby undercuts the moral hazard mitigation effects of cost sharing. One of the most significant cost control mechanism is called the DRG system, Diagnosis Relative Group System. Under the system, there is a prospective payment instead of a fee-for-service payment model is created. The DRG system of hospital payment transfer risk from the government to hospitals and eliminates incentive for hospitals to provide unnecessary expensive care to patients. So it is passed in 1980s, and once it's passed, the length of stay dropped significantly. But we have to acknowledge that it's dropping even before it is passed. There is no long-term effect on inpatient mortality due to the introduction of the DRG groups, even though some short-run increase in mortality is found in a subset of hospitals. Finally, there's a major cost control tool that Medicare cannot use, which is called cost effectiveness analysis, and a treatment that is proven effective in scientific studies, regardless how costly it is covered by the Medicare. So it seems likely that Medicare could reap substantial budgetary savings from CEA, but so far there has been little political will to introduce it to the Medicare coverage determinations. Finally, we're going to talk about Medicaid. It is a public insurance program, provides highly subsidized insurance coverage to low-income families who have no insurance, or pregnant women as well. Unlike the Medicare, which is run by the US federal government, Medicaid is jointly run by the federal and state government. So some states have a wide latitudes to set budgets, and state government also can decide eligibility rules and decide how generous their local Medicaid program is. And so as a consequence, Medicaid coverage and generosity can vary substantially from state to state. In 2009, Medicaid covered 62.5 million people. This is about a fifth of the US population, and its expenses totaled about $400 billion nationwide. Low income alone does not qualify one for Medicaid in most states. There are various other factors that including marital status, number of children, pregnancy, disability, health, and immigration status that can affect their eligibility. So Medicaid also have some cost control techniques. One of them is cost sharing. Enrollees typically obtain costs and curb moral hazard with a combination of eligibility and coverage restrictions. One way that states controlled Medicaid expenditure is by setting reimbursement rates at the low level. So a doctor treating a Medicaid patient receives only a fraction of the payment she would get for seeing a similar but privately insured patient. So as a result, Medicaid patients can have trouble finding a regular source of care because a lot of doctors choose not to accept Medicaid patients. 24% of low income reports that even though they have Medicaid, but they have lack of access to care. States also control costs by restricting the set of prescription drugs available to Medicaid enrollees and by setting reimbursement rates at a low level. So the list of drugs usually exclude expensive branded drugs when generic alternatives are available. This is nice, but there's sometimes also less access to prescription drugs for Medicaid enrollees. That is unique drugs that is expensive, and they could experience a difficulty to get access to those. Some states have also experimented with other forms of cost containment, including explicit cost-effective analysis. One thing about Medicaid is that it discourages some people from working. So because Medicaid eligibility sometimes draws a line on people's income. And so if someone's income is $100 above the Medicaid eligibility line, then this person would think that he or she should work less so that he or she earns $100 less money, but then he or she would be eligible for the Medicaid. Okay, lastly, one of the problems of the American model is that there is uninsurance in the society. In 2012, this is before the Obamacare, the majority of Obamacare come into effect. There are around 50 to 60 million people in the US that are not covered by any health insurance program. So we call them the uninsured. They can pay for medical care out of pocket, but they face the risk of a catastrophic health bills, and often they will end up deferring care until it becomes an emergency. The persistence of uninsurance has been a key driver of health policy reform in the US. So why don't Beveridge and Bismarck system has this problem? Because Beveridge and Bismarck system mandated people to get health insurance. Okay, let's talk about the 2010 health reform. This is what we call the Obamacare, or the Affordable Care Act, ACA. Most part of the law comes into effect in 2014. So they have thousands of, the law has thousands of provisions, but there are three major parts. The first part is they expanded Medicaid. The second part is there's an individual insurance mandate. And the third part is that it cuts to Medicare spending. Obamacare expands Medicaid coverage dramatically by forcing states to cover broader classes of people. It estimates to add 17 million people to Medicaid rolls. But a 2012 US Supreme Court ruling says that states can still opt out of this part of the law. The second part, an individual insurance mandate, it says that all citizens who do not have insurance through work going on a public insurance program must buy insurance on the statewide private market. This is designated to combat adverse selection. It's similar to the Bismarck managed competition that it mandates people to buy insurance, but people with low income may not be able to afford it, so they would receive some type of subsidies. And the third part is a cut to Medicare spending. Extending insurance coverage to millions, that is not cheap. So to help pay, Medicare is cut by $50 billion per year, but cuts are not specified by the law. Instead, cuts will be made by an independent board called the IPAB with an unusual amount of freedom. IPAB may invoke HTA. HTA is cost-effective analysis, which would be a first for Medicare. Okay, so we know that cost-effective analysis is still not into effect in Medicare until now. Okay, so to conclude, the American model with its mix of public and private insurance and care can be contrasted with the more egalitarian models popular in Europe and Asia. With the introduction of PPACA, the American model is undergoing substantial changes, but it's still keeping its distance from the Beveridge and the Bismarck models.